We're just about an hour. Good morning, everyone, for our November AIDS clinical conference. And this Dr. Wood doesn't really need an introduction. Everyone knows him from Mountain West AETC and as director of the HIV ECHO program for Mountain West. I see many people on today are part of the ECHO community, so welcome. This is our annual talk that Dr. Wood, who is a professor of medicine here at University of Washington, gives to us about an update in ART. And so I'll let him get started. Thanks so much, Brian.
Thanks, Trisha. And thank you, Chris and Victor, for the behind the scenes work. Honored to be invited back. I always enjoy doing this. Those of you who know me know I like talking about ART, I like talking about controversies, and I like hearing from you. So I plan to do a lot of all of those things this morning. I want to be clear that I have no conflicts and no financial relationships or disclosures. I will be giving my opinion on a lot of ARV related things. I have no financial interest in any of them. I'll focus on controversies. I'll talk about some new things coming. And again, I will ask you your opinion on a lot of things. If you are not a prescriber, no worries. I know this is ART and a little more prescriber focused. I will try to bring us back to some take home messages, even if you are not a prescriber as well. And let's start, Chris, if you don't mind opening the first poll. Bit of a warm up. This was mentioned at last ACC as well. Would love to just hear from you. What's your opinion? Fact or fiction? Abacavir increases risk of major adverse cardiovascular events. We'll give a few seconds and then we'll see how everybody responded. Let's go 5 more seconds, Chris. Perfect. All right, hopefully everyone can see majority commented or responded fact. I would agree with that. I have really come to think of this as fact. I figured this would be one of the less controversial ones, but I do think it's important. I will just show you new data from the last year, not all of the past data. Hopefully everyone was able to see the result. And I'll keep moving. I think the most important new data on this came from the Reprieve trial. Many of you are familiar with Reprieve, a very large global phase 3 randomized control trial, which compared pitavastatin to placebo for adults with HIV with low to moderate estimated risk of cardiovascular disease. I'm not going to go through the main result, but this led to important new statin guidelines in the HHS adult and antiretroviral treatment section. If you haven't looked at that, I'd encourage you to do so. We have some resources on the national HIV curriculum as well. But this important new data, specifically related to abacavir, was presented at IAS. They looked at the risk of major adverse cardiovascular events in the trial that was mostly MI or stroke, comparing participants with current abacavir exposure, prior exposure, or no exposure. And you can see here estimates of how many participants fit each of those categories. I won't belabor this, but this is the principal result. Overall, abacavir exposure compared to none was associated with a higher incidence of major adverse cardiovascular event. You can see the adjusted hazard ratio here. Interestingly, both former use and current use were significantly associated with major adverse cardiovascular events. And interestingly, there was no association with these other antiretrovirals. And you can see here cumulative incidence of major adverse cardiovascular event. Now, there have been a lot of associations. There also are some studies suggesting mechanisms. Abacavir may increase platelet activation. And I have really come to think of this as more of a fact. I have really been encouraging a lot of my patients to switch off of abacavir, especially those with cardiovascular risk, but even those without cardiovascular risk, I just don't love it as a medication. I've been encouraging a lot of people to make a transition. One of our longtime dedicated ECHO participants, George Schultz, recently commented that in clinic, he's been untriomecing a lot of people, and I would comment that I've been doing the same. The HHS adult and antiretroviral treatment guidelines recently made a major update also to reflect the downsides of abacavir. These are the recommended initial regimens for most people with HIV. For those who do not have a history of using cabotegravir for PrEP. If someone is diagnosed with HIV and they've ever received cabotegravir as PrEP, they should get boosted darunavir with 2 NRTIs as their first regimen if you are awaiting the genotype. Assuming a person has never taken cabotegravir as PrEP, this is the simplified list, which is bictegravir with tafenoprocybine, dolutegravir with tafenoprocybine, or TDF-emtricitabine or TDF lamivudine. Dolutegravir bacteremivudine has been removed from this list. It has been moved to the consider in special circumstances, along with NNRTI-based options and the boosted darunavir-based option. Again, this is for people who've never received cabotegravir. So this is a simplified list. The other option here, dolutegravir lamivudine, 2-drug therapy. I'll tell you, I have not yet prescribed as a first regimen. It is on the list with these caveats. There are some data suggesting that it's probably effective even with viral loads above 500,000, even if you are awaiting the genotype result, as long as once you get that result, you act reflexively if there are resistance mutations that might affect this combination. I do think hepatitis B is a really important contraindication, but for me, this has been more a switch strategy than a first regimen, but this is the simplified list. So again, no dolutegravir, abacavir, lamivudine. And I'll just put this out there for consideration, and I'd love to hear from you. Is this the end of the road for abacavir? I cannot remember the last time I checked an HLA B5701 or ordered dolutegravir, abacavir, lamivudine as a first regimen. I have some folks who are still on it. Again, I'm talking to a lot of them about switching, such as to dolutegravir, lamivudine to just cut out the abacavir. But I really can't remember the last time I recommended it or prescribed it as a first regimen. So put this out there. Feel free to comment in the chat. Would love to hear from you. Are there scenarios in which you're still recommending it as a first regimen or as a switch regimen? As I've brought this up in other forums, like ECHO, people have brought up that there are cost considerations. There may be situations where a person really wants a single tablet, really needs 3 active drugs, they're B5701 negative, maybe it will still make sense. Maybe with significant renal dysfunction, if you still want 3 active drugs in a single pill, maybe with some drug-drug interactions, but I would argue we have enough other options these days that I think it's going to be pretty rare to recommend dolutegravir, abacavir, lamivudine going forward. Would love to hear your thoughts as well. One of the other corollaries, one of the other reasons that I'm not seeing an indication for dolutegravir, lamivudine, abacavir these days is there's really now strong data for dolutegravir, lamivudine, 2-drug therapy. So eliminate the abacavir, 2-drug therapy in a lot of different settings, including in the setting of an M184V or I, which is an NRTI resistance mutation. There's question about whether dolutegravir 3TC or dolutegravir lamivudine would work with this mutation, because this does cause very high level resistance to lamivudine, and we know from other studies that dolutegravir monotherapy does not work. However, this and other data really suggest that dolutegravir lamivudine, even in the setting of an M184V or I, remains effective. And this and other data really suggest that if you have dolutegravir plus partially active or even inactive NRTIs, it remains effective, which I find fascinating because dolutegravir monotherapy does not work that well. But dolutegravir plus partially active medication seems to work fine. This study called Solar 3D, led by folks from Connecticut, was prospective open label, and they simply compared individuals taking dolutegravir 3TC with a history of M184V or I to those taking dolutegravir 3TC without that history. All enrollees were adults with suppressed viral loads for at least 6 months, taking stable traditional ART. All had prior virologic failure and at least 2 prior ART regimens. They did not exclude anyone based on CD4 count, integrase strand transfer inhibitor, or INSTI experience, past NRTI resistance, or these mutations as mentioned. Their primary endpoint was the proportion of participants with HIV RNA above 50 copies at 144 weeks. In their intention to treat analysis, importantly, there was no difference in virologic efficacy comparing those individuals who received dolutegravir lamivudine, again, 2-drug therapy, in the setting of an M184V or I mutation versus with no history of that mutation. Now, there are limitations to this data. It's not a huge trial, but it does agree with other studies and with a meta-analysis that looked at this. I do want to point out one other thing here that I find interesting that came out of this study. In the table to the right, you can see those individuals with an M184V or I on a historical genotype, usually a traditional RNA genotype. Of those 50 individuals, 41 had a proviral or DNA, also called archive genotype sent. So these 41 individuals known to have M184V or I on a past RNA genotype got a proviral or DNA genotype, and only 15 actually had the M184V or I detected, only 37%. I bring this up because I come back to something we've mentioned at these meetings before. An archive or DNA genotype has low sensitivity. If you don't see a mutation there, you cannot always trust that it is not present. To me, this just really emphasizes that point and why we only order archive or DNA genotypes when we really have no other option and no data and no records. For all of these reasons, because of the efficacy data for dolutegravir lamivudine, I'm using it fairly frequently as a switch strategy for individuals who have been suppressed for a long time on another regimen. Maybe there's an indication to help get them off of TAF or TDF, or to drop the abacavir and switch to this 2-drug maintenance therapy. So I do find myself recommending or prescribing this a fair amount. I have found over the past year or so, it seems like insurance is covering the combined tablet more often than they used to. I still have situations where insurance does not cover it and I need to prescribe the tablet separately. I've also heard others like Matt Golden argue that if we could switch everyone to dolutegravir plus generic 3TC, there would be incredible healthcare savings, incredible savings to the healthcare system. So there's a lot to consider here with this combination. Now, one additional thing to consider is hepatitis B status. And so I'm going to switch gears. I'm still going to think about switching ART, but I want to ask you this question about switching in the setting of an isolated reactive hepatitis B core antibody or an isolated hep B core antibody positivity. So fact or fiction, isolated hep B core antibody should be considered a contraindication to switching off TAF or TDF, meaning if somebody has an isolated positive hep B core antibody, you should not switch off TAF or TDF. Fact, fiction, or we need more data. I see answers rolling in. I appreciate it. Even if you're not sure, go ahead and give your inclination, and let's give that a couple more seconds. All right, Chris, that looks like a good array of input. Thank you so much. So 15% fact, 41% fiction, and 44% actually the largest response being we need more data. I also would like to see more data on this. One of the reasons I decided to dig into this, so everyone can see the results. One of the reasons I decided to dig into this, it's a question that's come up. It's come up on Echo. It's come up in other forums. And then ID Week, this QI protocol from Mount Sinai was presented, in which they made a concerted effort to both improve rates of checking hepatitis B serologies and encouraging clinicians to consider the results before switching, with this note that if someone has a positive core antibody and a negative surface antibody, they should not switch to 2-drug antiretroviral therapy. So I wanted to figure out more what was out there. And I found a couple things, though I'm going to come to the punchline of I agree we need more data and better guidance, but I think there are really important things to consider here. So first, this abstract from Italy was presented at this past CROI. This was a retrospective review that included 41 individuals who switched off TDF or TAF in the setting of a reactive hepatitis B core antibody. Some also had a positive surface antibody, some did not. 15 switched to dolutegravir rilpivirine, that's a 2-drug oral ART option. 26 switched to long-acting injectable cabotegravir rilpivirine, and the median follow-up was 9 months. 34 of those 41 individuals had a positive hepatitis B core antibody and positive surface antibody, and there were no hepatitis B reactivations. 7 had isolated positive core antibody, meaning surface antibody negative, and one of those individuals experienced a reactivation of hepatitis B after they switched to long-acting injectable cabotegravir pivirine. The conclusion of these investigators was, if switching off of TAF or TDF in the setting of a reactive hepatitis B core antibody, we should monitor ALT, and if it rises, check the hepatitis B DNA. Here is the one person with Hep B reactivation after switching to long-acting cabotegravir. You can see about 3 months later, their ALT increased, and corresponding to that, their hepatitis B DNA increased, and they seroconverted from negative surface antigen to positive and negative E antigen to positive. They did some other sophisticated data using stored samples to try to prove that this was not a new infection and instead a reactivation. Small numbers, but there are other data that tend to corroborate this. This was a study presented at ID Week, not this year, but last year, that got some attention. This is from the Veterans Aging Cohort Study. They again did a retrospective review of all individuals with HIV with a positive hepatitis B core antibody who switched off active hepatitis B ARVs, meaning they switched to a regimen that did not include TAF, TDF, FTC, which is emtricitabine, or 3TC, which is lamivudine. So they switched off all of those. They identified 39 cases of hepatitis B reactivation. You can see in the table to the right, I've circled in blue, of the overall at-risk population. So this is the individuals with HIV with a positive Hep B core antibody who switched off all hepatitis B active therapy. There were 39 reactivation cases for an overall reactivation rate of 0.7%. The median time to reactivation was 292 days. Most reactivations occurred within a year, but the longest was around 5 years. Now, importantly, I've circled 2 things here in red. Those who had a positive core antibody, who were never surface antigen positive and never surface antibody positive, so true isolated core antibody positivity, had a reactivation rate of just over 1%. If individuals also had a positive surface antibody along with their positive core antibody, the rate of reactivation was decreased. Again, limited data. We don't know details of these clinical cases of reactivation. We don't know if they received chemotherapy or rituximab. We don't know their CD4 counts. We don't know if there were other triggers for reactivation. I think we need more data about predictors. But to me, this does emphasize that when switching ART, we need to review hepatitis B serologies and consider the risk of reactivation. One more study, and then I'll give a bit more on my interpretation. So this was a composite review of the randomized clinical trial, the registration trial data for dolutegravir 3TC. Gemini and STAT were trials that looked at dolutegravir 3TC as initial therapy. Tango and Salsa looked at dolutegravir 3TC as a switch option. So these investigators simply reviewed all the data from those trials, looked at individuals who received dolutegravir lamivudine with an isolated positive core antibody. The overall N was 76, and in this series, there were 0 cases of Hep B reactivation. So they concluded that dolutegravir 3TC, which is dolutegravir lamivudine, is safe and effective in the setting of a positive core antibody. So what do we do with that? How do we put it all together? I'll share with you my thought process. Would love to hear from you if you agree or disagree or would do anything differently. I would never bill myself as a hepatitis B expert. The Hep B experts out there, please educate me if you would do anything differently. So to me, this data emphasizes it is extremely important to check hepatitis B serologies, to vaccinate if non-immune, including if a person with HIV has an isolated Hep B core antibody. And remember, if vaccinating in the setting of an isolated positive core antibody, we're looking for a surface antibody response to above 100. And then if somebody does not reach that threshold, does not respond to vaccination in the setting of sorry, let me say that differently. If somebody does not if somebody does not reach that threshold after vaccination, we should probably do more investigation to make sure they do not have occult hepatitis B. I do think it is ideal to vaccinate and document a protective surface antibody before switching off TAF or TDF. And then this is my amalgamation of the data available to date. If somebody does have a positive core antibody and they need to switch off TAF or TDF, the risk of Hep B reactivation is low, probably 1% or so, but it is not zero. The risk seems to be lower if they are also surface antibody positive. The risk seems to be higher if they are also switching off 3TC or FTC. The risk may also be higher if their CD4 count is low. So anytime someone switches off Hep B active drugs and they have a positive Hep B core antibody, then we should monitor ALT and consider checking a hepatitis B DNA PCR if the ALT rises. I see in the chat from Harry getting the Hep B vaccine before changing to double therapy. Yes, thanks for clarifying that. I would say that if someone is not immune, if they have an isolated Hep B core positivity, the ideal would be to give them a booster dose, Heplisav if you have access to it, or if not, then other strategies, and then document that they are immune before switching off of TAF or TDF. I think this is especially important if you're also switching off 3TC and FTC. The ongoing presence of 3TC FTC seems to be somewhat protective, not enough to treat Hep B co-infection, but maybe it helps to prevent reactivation. But for example, if you are switching to dolutegravir rilpivirine dual oral therapy, or if you are switching to long-acting cabotegravir rilpivirine, you are then avoiding any active hepatitis B drug. And I think this becomes especially important to, again, review serologies, vaccinated if not immune, and consider the risk of Hep B reactivation, especially if you switch and ALT rises for any reason, consider hepatitis B reactivation. I hope that made sense. I hope it's helpful. Would love to hear from you if you disagree in any way or would do anything differently. Otherwise, I think you all guessed this was coming. You know I've tried to pay attention to this topic. You know it's controversial. We're going to talk more about switching. We're going to talk more about dolutegravir 3TC and long-acting injectables. I just want to hear your opinion on this. I do not think there is a right answer. Do you think integrase inhibitors cause weight gain? Cause, and I highlighted cause. Do you think the drugs themselves are responsible for weight gain? Let's give that 5 more seconds, Chris. Again, looking for opinions. I'm posing these questions to you because I don't think they've been fully answered. Okay, we've got a smattering here. I love this. Shows the controversy. 44% fact, 35% fiction, 21% we need more data. I will just share here. There certainly are associations. I'll talk about this. I am leaning more towards fiction and we need more data. And I'll tell you why in a moment. But let's go to the next poll, Chris, and ask everybody this one. What about tenofovir alafenamide? What about TAF? Does it cause weight gain? Is the drug responsible for weight gain? Please share your opinion. All right, Chris, let's share that. I mean, fascinating. It shows the ongoing controversy, really pretty evenly split here. 37% fact, 33% fiction, 30% we need more data. I am going to see if I can prove to you that this is fiction. I really have come to think that this is untrue, but it is not a fully answered question. I will very readily admit that. So I'm going to focus on the newest data, not all the past things. I've talked before about some of this. We know that there's an association between certain classes of ARVs and specific ARVs and greater weight gain over time as compared to other classes and other drugs. There clearly is an association. This study was just published in October. I thought it was kind of a different strategy to look at this. It was retrospective data limited only to individuals who started ART within a year of seroconversion. Now, why did they choose to do that? They chose to do that to try to eliminate the impact of the long-term catabolic effects of untreated HIV infection and to try to eliminate any aspect that could be quote unquote return to health. Now, I think we could debate about, the validity of this strategy, but that's why they did it this way. Median follow-up 3 years. Clearly, everyone who started ART, and this was all treatment naive individuals, everyone who started ART gained weight over time, and clearly there's an association, there's a difference between classes. I'm not showing it to you here, but those who received TAF as part of their regimen also gained more weight than those who did not receive TAF. Clearly an association. There's a nice editorial here which argues for several reasons why this data is limited and why association does not prove causation. So diving into this a little more, I think the associations are there. I think clearly people tend to, not everyone, people tend to gain more weight over time with certain meds and classes than others. But are the drugs themselves really causing or promoting or triggering weight gain in some way? I am not convinced. This is an interesting trial published last year by the group at UCSD. It was a randomized, double-blind, placebo-controlled 96-week trial for individuals taking stable ART with suppressed viral load, and everyone was randomized to one of these groups to intensify or not intensify their stable ART regimen. Their goal was actually to see if intensification improved neurocognitive function, which it did not, but a post hoc analysis allowed them to look at changes to weight. And so the 3 groups were, again, adding to their stable ART, adding dolutegravir and maraviroc, adding dolutegravir and placebo, or adding dual placebo. What this allows, I think for the first time ever, is a comparison of weight change with dolutegravir versus placebo for individuals with suppressed viral loads. The punchline is the changes in weight were very modest and were not different between any of the groups. The yellow line here is actually the placebo, the dual placebo, and the purple and pink are the groups who received dolutegravir. So you would think that if you added dolutegravir for one group of individuals, added placebo for the other, you would think if dolutegravir were triggering weight gain, the group receiving dolutegravir would gain weight faster. Would gain more weight. You would think that is not what they saw. Definitely limited. The trial was not designed to look at weight gain. It was designed to look at something else. It's a post hoc analysis. The baseline regimens were mostly efavirenz, rilpivirine, or darunavir based, and a lot of people received TDF. So limited, but I think very suggestive that dolutegravir does not trigger weight gain. I've heard some calls for similar trials with TAF. For example, if we enrolled people taking dolutegravir lamivudine, randomize them to add TAF or not add TAF, we could look at weight change over time. I don't know if that will ever happen, but I'm hearing calls for that. So that's some suggestion that the integrase inhibitor itself does not cause the weight gain, even though there's an association. What about TAF? The Swiss HIV cohort group has done some, I think, really remarkable research related to this as well as other related topics. This particular trial really caught my eye. It was just published. It's pretty hot off the presses. They looked at 6,555 individuals who had received at least 6 months of TAF, and they looked at what happened if they looked at what happened comparing the group that either continued TAF or switched off of TAF. And you can see here, those who continued TAF in blue compared to those who switched to TDF in red. Continuing TAF, weight pretty stable. Switch to TDF, weight decreases. What about if you don't switch to TDF? What if you just stop TAF? Interestingly, weight does not change with just stopping TAF. To lead to weight loss, it's really the switch to TDF that leads to weight loss. Stopping TAF does not lead to weight loss. This and other data all are really consistent on that. Again, weight change is not observed if you switch to dolutegravir 3TC or to injectable cabotegravir rilpivirine. So I would not tell anyone switching to one of these regimens, stop TAF, that they are going to lose weight. I absolutely would not promise that. The data are pretty consistent that what leads to weight loss is switching to TDF, not stopping TAF. I won't go through this in a lot of detail. This was also just published, and it really supports the data I just showed you. So this is a composite of all of the randomized control trials that included individuals who either continued TAF or stopped TAF. I'll let you look at the paper in more detail if this is an interesting topic to you. But the punchline is those who stopped TAF did not consistently lose weight. Again, if we look at one trial that had individuals that both stopped TAF and that stopped TDF, if people stop TDF, they tend to gain weight. If they stop TAF, they tend to not have any changes. What do we do with this? I think it's really hard to know. It's certainly still evolving. I'll come back to my interpretation and how I counsel people in clinic in a minute. The other really key question is what happens when people who have gained weight on ART, especially integrase inhibitor-based ART, what happens when they switch to other non-integrase options? I think this is definitely an area in which we need more data. The data available to date are pretty limited. This trial just published in September was called Define. In this trial, they enrolled individuals who had suppressed viral loads, who had experienced at least a 10% increase in body weight, taking an integrase inhibitor with TAF FTC. There were just over 100 individuals in the trial. They were randomized to either switch to darunavir, cobicistat, TAF FTC immediately or after 24 weeks. The overall conclusion is there was no difference in weight change at 24 weeks. Only in the group who switched immediately, if you look later after the 6-month time point, maybe there was a trend towards weight loss. Their conclusion is, well, if we switch integrase inhibitors to boosted darunavir, maybe after a long time of the integrase inhibitor out of the system, maybe some people lose some weight. I'm not ready to use this to start encouraging changes. I think we really want to know what happens after individuals switch an integrase inhibitor to doravirine. We do not know yet. The ACTG 5391 or Do It trial has stopped enrollment. I believe analyses are ongoing. I believe we'll see data within the next year. I think that will be very informative. So far, all we have are retrospective observational studies that give the answer of a very firm maybe. Maybe some people experience a small amount of weight loss after switching integrase inhibitor to doravirine. Unclear how clinically significant. I won't go through all of it. I really think we need randomized controlled trial data to help answer this question. Coming back to this review written by David Wool and colleagues, they proposed this, I thought, intriguing model for return to health weight gain on ART. So they propose that there are individual factors that may enhance the amount of return to health weight gain a person experiences when starting their first ART regimen. These factors may include pretreatment viral load and CD4, baseline weight before starting ART, genetics and pharmacogenetics, and social determinants of health. There may be individual factors that attenuate or reduce the amount of weight gained. And then for ART, for HIV treatment, antiretroviral associated factors, they actually propose that TAF, bictegravir, dolutegravir, and cabotegravir are neutral. And the cause for the associations we see are TDF and efavirenz, especially individuals who, because of pharmacogenetics, end up with higher than average efavirenz systemic levels, that these are the attenuating factors. And when we compare the two, this is the reason for the association. So definitely controversial. I mean, as the poll showed, I think really an unanswered question. I think we need more data. I think we need more guidance. And as many of you know, I really want to know the mechanism. I really want to know if we're saying that these drugs either enhance or attenuate weight changes and cardiometabolic risk factors. I really want to know why and how. I thought this was an intriguing study from this past CROI last March. This group enrolled individuals taking TDF or TAF, not high numbers, but enough, I think, to be intrigued by this. They performed gastroscopies and biopsies of the proximal and distal duodenum, compared the pathology of those taking TDF and TAF, and those taking TDF clearly had more damage, clearly had differences in the GI tract compared to those taking TAF. The TDF group had more villus damage, especially in the proximal duodenum. They had increased markers of enterocyte damage. There were no differences in mitochondrial damage, but this group proposes that maybe the reason body weight and lipids are lower when we compare TDF to TAF is because of this gut enterocyte damage. I have seen the occasional person who really has trouble taking TDF because of nausea, diarrhea, other GI intolerability. So I was intrigued by this, but I think definitely we need more data to help prove it. So when we're considering TDF versus TAF, I really think it's case by case, different for each individual. There's a lot to consider. In addition to insurance and cost, the options with TDF tend to be larger. We need to do more monitoring for renal and bone toxicity. It seems that TDF suppresses weight gain and lowers lipids. I really want to know why. Is that a reason to favor TDF? I don't know. I worry that there is some sort of, gut enterocyte damage going on, and we don't fully understand why these things happen. So I'd like proof of the mechanism first before saying, TDF has benefit. TAF is a smaller pill, lower renal bone risk, but seems to have much more neutral effects on weight and much more neutral effects on lipids. So to me, this is very individualized, very case by case. When considering the second generation integrase inhibitors, dolutegravir, bictegravir, compared to other ARB anchor drug options, doravirine, the NNRTI, or boosted darunavir, the boosted PI, to me, the balance still for the vast majority of individuals favors use of dolutegravir or bictegravir. For me, it's very case by case, considering a switch to one of these or considering using one of these. This is definitely my opinion, this is definitely my opinion, and would love to hear anyone who feels otherwise. Totally open to learning from you and your experience. I tend to favor dolutegravir, bictegravir for the vast majority of individuals because people tend to tolerate and stay on these meds longer. They have a relatively high resistance barrier, relatively high tolerability, and relatively few drug-drug interactions. The other options, maybe there's less weight gain, but I really don't think that's proven. I want to see more. In the case of doravirine, there's definitely a lower barrier to resistance. In the case of boosted darunavir, there are definitely more GI side effects and more drug-drug interactions in general. That is totally my interpretation. I also want to emphasize, I do not think stopping TAF helps people lose weight unless you switch to TDF. And I really want to know more about switching off integrase inhibitors and what is the best clinical strategy if a person has gained weight while taking an integrase inhibitor. One of the big conversations at ID Week was, is it better to switch or is it better to try to get weight loss meds like GLP-1 receptor agonists? Of course, that's really hard to do. There's tons of insurance and cost barriers. So again, to me, that decision ends up being something I talk to the person about and really help to individualize. Please put your reflections in the chat box. If you totally disagree, I am open to hearing that. Love to hear discussion. And otherwise, let's talk more about switching meds. This time we're going to talk about long-acting cabotegravir. So fact or fiction, long-acting cabotegravir is an effective HIV treatment option for individuals with detectable viral loads. Yeah, and thanks for the question about PrEP. So both for PrEP and for PEP, with considering TDF FTC versus TAF FTC, I think there's a lot to consider. I do think there are a lot of people taking TDF FTC for PrEP who tolerate it well, for whom it's very effective. I am not ready to say they need to switch to something else. I really want to know more. I am still recommending TDF FTC or TDF 3TC as generic for PrEP, but yes, it makes me want to know more, and it makes me want to know about long-term side effects. I think we need more data, and I do appreciate that question a lot. Okay, Chris, let's go ahead and show that one. Perfect. This has certainly evolved over time. So 60% saying fact, a few fiction, and a fair amount we need more data. Again, I'm just going to show you some new things. We've talked about prior data. This is a composite, not a complete list. I've left out the case studies and very small under 10 case series. But I show this just to say that the data for long-acting cabotegravir in the setting of missed oral ART doses, in the setting of viremia, has increased, and the paradigm around this has shifted to some degree. Matt, TAF FTC 30 times more expensive than TDF-FTC. Really appreciate you putting that in there. Such an important point. There is a lot to consider. Again, I'm not ready based on the data to start encouraging people to switch off of TDF-FTC or TDF-3TC, the generic. I do want to know more about long-term side effects and toxicity. Thank you, Matt. The data has increased. There was a lot of discussion about this at ID Week, including a fantastic session that Jihan Budak led. The overall consensus is that long-acting injectable cabotegravir piperine can be a very powerful tool, to help people with advanced HIV who just cannot succeed with oral ART for any number of reasons. The overall success rate does seem to be lower than in the registration trials, but probably higher than trying to push forward with oral ART for individuals for whom it has just never succeeded despite a lot of adherence support. I'll let you dig into this more if you really want to. I'm just going to highlight two things that are fairly recent. This updated analysis from the UCSF Ward 86 team was just published in October. This was limited to individuals who started long-acting injectable cabotegravir piperine in the setting of a detectable viral load. We've talked previously about data from this group. They provide a lot of adherence support. They have a rather unique setup with insurance and coverage and access, but they have also been real sort of leaders in pushing us to consider injectable cabopiperine for individuals with detectable viral loads. Individuals with detectable viral loads were not included in the initial registration trials. So this is sort of a paradigm shift, but it's really important. Those who started in the setting of viremia were overall 59 individuals. You can see here a description of their CD4 counts and viral loads before starting. Just over half had a history of unstable housing or were unhoused. 63% were using stimulants, meth, or cocaine. Again, there was a lot of adherence support and outreach offered. At 48 weeks, 47 of the 59 had a viral load below 50 and were still receiving long-acting cabopiperine for an overall estimate of those succeeding at 48 weeks with long-acting cabopiperine of 80%. That 80% is pretty consistent, as I'll talk more about. Quick glance at the time. Okay. So of those 12 who did not achieve that outcome, 5 actually decided to switch back to oral ART and did remarkably well. They comment in this paper that all the outreach, all the support, starting the injectable sort of remotivated people to succeed with the ART. And I was surprised by this. Folks who historically had not succeeded with oral ART actually succeeded after switching back. There were 5 virologic failures on long-acting cabopiperine. All 5 of those did develop new resistance. All 5 started with a viral load above 10,000. Most had low CD4 counts. And you can see here, some of them, because of new resistance or low-level viremia, changed, such as adding lenacapavir or switching to lenacapavir with cabotegravir. And if you include all of those individuals, including those folks who changed to other therapy or added lenacapavir, you end up with 54 out of 59 or 92% who succeeded. So punchline, this is a powerful tool for some individuals, a lot of adherence and outreach support needed. Some will not succeed and will need to switch back to oral ART or add additional therapy, but a remarkably high percentage of people can succeed with this therapy. The ACTG 5359 or Latitude study was also stopped early by the DSMB because of the success of the long-acting injectable option. So many of you have heard about this. There was a nice presentation by Adi Rada at CROI, and I'll just go through a couple of the key points. So individuals were enrolled if they had a history of not taking oral ART. They had some definitions of what that meant. Step 1 was standard of care oral ART with at least 2 active ARVs with a lot of adherence support and conditional economic incentives. Those who achieved a HIV RNA or viral load below 200 copies entered step 2 and were randomized to either long-acting cabopiperine every 4 weeks or standard of care oral ART. Step 3 was an open label continuation, and then step 4 was for anyone who received at least 1 injectable dose and for whatever reason it was not right and chose to do oral ART instead. But during step 2, a planned interim analysis showed the relative efficacy of the long-acting injectable option, and it was recommended to stop enrollment and randomization in the trial. Interestingly, even though to enter step 2, people had to have achieved a viral load below 200, there were a proportion whose viral load was above 200 at the time they started cabopiprine. You can see some details there. And then I will just say that every outcome favored cabotegravir. You can see in the red bars, the long-acting injectable therapy, and the blue bar, standard of care oral therapy. The outcome definitions were a little confusing. Regimen failure was virologic failure or treatment discontinuation for any reason. Virologic failure is the outcome here. Treatment-related failure was discontinuation due to adverse effects, and then there was permanent treatment discontinuation. You can dig into the details if you want. I will just say that every outcome favored, even if not statistically significant, favored the long-acting injectable therapy. All of this has led to new language in the HHS guidelines to say that on a case-by-case basis in select individuals with persistent virologic failure, despite intensive adherence support on oral ART, if they have no resistance to cabopiprine with shared decision-making, we should be considering the long-acting injectable option. Data is limited, we need more studies, but again, this is a very powerful tool that has helped some people who have never achieved a suppressed viral load in the past achieve virologic suppression. Data for long-acting cabotegravir and subcutaneous lenacapavir in the setting of history of missed oral ART doses or history of resistance and detectable viral loads is also accruing. This is a case series from University of Mississippi in which they enrolled individuals with mean viral load of 36,000, all with rilpivirine resistance, one with cabotegravir resistance. They all received injectable cabotegravir and subcutaneous lenacapavir, and all did quite well. There was also this paper written by Monica Gandhi, which is a case series from 4 institutions. Again, individuals received lenacapavir plus cabotegravir with or without rilpivirine. There were different reasons for that. Some individuals had multiple reasons, and overall, people did quite well. So there's been call of a clinical trial of this combination, and I hear rumors we'll see that in the relatively near future, though I can't say I know details. So long-acting therapy in the setting of a detectable viral load can be considered on a case-by-case basis, and for some individuals can be extremely successful. I'll leave it at that, open to questions, open to reflections. We'll talk about this. Fact or fiction, new oral ARVs in the pipeline will make a major difference for people with HIV. Clearly no right answer, would love your opinion. All right. Chris, why don't we show that? Okay, talking about the future of oral ART, not surprising, to be determined. I will just say, I am finding I'm bringing this up more often than I would expect with patients in clinic, folks who really want to simplify, folks who really want long-acting therapy and just are not candidates right now because of resistance, folks who are taking salvage regimens. I'm having a fair number of conversations in clinic where I'm just saying, look, I'm sorry, you are not a candidate for what we have right now, but there are new things coming. So let me just mention a couple things coming. Again, this is new oral drugs being developed. I'm not going to talk about BNABs and other very long-acting things this year. The oral regimens, I do think are going to make a difference for people with long ART history, for lots of resistance, taking salvage regimens. So these first 2 rows are new daily oral 2-drug regimens being developed. Daily doravirine with islatravir. We've seen phase 3 data. It was promising except for the negative impact on lymphocytes and CD4 count from islatravir, but the dose has been changed. The phase 3 studies are being repeated with a lower dose, and I think it is extremely promising. The combination of a second generation high barrier resistance integrase inhibitor like bictegravir with lenacapavir, oral lenacapavir in this case, the capsid inhibitor is also extremely promising. And for individuals who have a lot of multi-class resistance, but no significant integrase resistance, I think this could end up being a really effective 2-drug once-a-day therapy. But then, probably more exciting, these weekly oral options, lenacapavir with islatravir, or these 2 novel drugs, which I'll talk more about on the next slide, can be dosed once per week orally and should be options for individuals even if they have significant multi-class drug resistance. I think we are going to start seeing data, in these first 2 rows for these options in 2025, and then hopefully not long after that for these others. I'll just highlight these 2 weekly oral drugs. This first one, called 1720, is an oral weekly quote unquote 3rd generation. So if bictegravir and dolutegravir are 2nd generation integrase inhibitors, this is a 3rd generation, called that because it retains activity even in the setting of common integrase resistance mutations. Potent, high barrier to resistance, long half-life, again, dosed once weekly, generally well tolerated, and will be an option for a lot of individuals. Studies are combining it with this novel oral weekly lenacapavir prodrug, which has the advantages of higher drug levels in the body, smaller tablet, and again, oral weekly dosing. There are initial ART and switch studies launched fairly recently, August and October, if I'm understanding correctly. And again, very promising once weekly oral therapy in relatively new classes that will be an option for a lot of people with drug resistance. Okay, I have just 2 more controversies, then I'm also going to ask you what controversies I missed. How about this? Fact or fiction, rifamycins like rifampin and rifapentine should be avoided in persons taking TAF. Fact, fiction, or we need more data? Thanks for weighing in. Chris, why don't we show that? We keep moving for the sake of time. Again, quite a spread. So showing that, showing again the controversy around this. I will just emphasize that the HHS adult and adolescent ART guidelines have been updated to reflect that there are at least PK data showing that the rifamycins combined with TAF are probably okay, but the data is limited, so they also encourage closer viral load monitoring if you are using this combination. The data comes from a PK study in volunteers without HIV who took TAF FTC for 28 days, then TAF FTC plus rifampin, then TDF. Not surprisingly, in the setting of rifampin, levels of the active metabolites in the plasma decreased, but the data that is being cited and is in the guidelines comes from the PBMC levels of the active metabolite. Here is with TAF, here is with TAF rifampin, and here's with TDF. So the punchline is, even though rifampin lowers TAF levels in PBMCs, those levels remain higher than with TDF alone. So this has been incorporated into the guidelines. They highlight this, they cite this as the data, and they say that if you are going to combine TAF with a rifamycin, you should monitor the viral load more closely. Again, for me, this is case by case. What are my ART options? How big an issue would it be to change a person off of TAF to a different regimen, or can I combine them and maybe do monthly viral load monitoring instead of less frequent viral load monitoring? I've put here a table of the options with reminders of when the anchor drug the dose needs to be adjusted, and then the caveats around TAF FTC. Look at the HHS ART guidelines. They've been updated to reflect this data. It's PK data. There's not a lot of clinical outcomes, but I do think we can consider TAF rifamycin combinations in certain clinical scenarios. And that brings me to my last controversy. And then I also want to hear which controversies you feel like I missed. So how about this? I actually have 2 questions around the same controversy. Fact or fiction, emtricitabine and lamivudine require dose reduction if the estimated GFR creatinine clearance is 30 to 49. Chris, let's show it. Okay, majority saying fiction. I would agree, and I'll tell you why in a moment. How about this? I think this is tougher. emtricitabine and lamivudine require dose reduction if the estimated GFR or creatinine clearance is below 30. Let's assume not receiving hemodialysis, not on intermittent hemodialysis. GFR below 30, not on dialysis. Okay, Chris, let's show that. More of a spread, but 44% saying fact. So why do I bring this up? If you look at the package insert for emtricitabine or lamivudine, or if you look at UpToDate or some other resources, it will recommend you reduce the dose if GFR drops below 50. In clinical practice, I do not do that. That was based on single dose PK data, not based on clinical outcome data. And I find that these drugs are so well tolerated that especially in the scenario with a GFR 30 to 49, I do not break up co-formulated tablets. I do not reduce the dose. And even in some instances with GFR below 30, I don't, but that for me really depends on the situation and what my other options are. There are not stellar data on this. The best data I think comes from this retrospective cohort study back in 2021. They simply compared individuals receiving lamivudine or 3TC at 300 milligrams daily to lamivudine or 3TC at 150 milligrams daily with an estimated GFR between 30 and 49. And the take-home message is that there were no severe side effects, no severe toxicities, no strong reason to avoid full dose 3TC in this GFR range. We do not have the same data for GFR below 30. So this is my strategy. Again, my interpretation. If someone has an estimated GFR between 30 and 49, I don't break up co-formulated tablets. I do not dose reduce 3TC or FTC. If someone has a GFR below 30 and they're not on intermittent hemodialysis, I think it's case by case. Ask about side effects, GI toxicity, things like that, but I find those to be rare. Consider changing, especially if you also need to switch off of TAF. I do think the renal insufficiency dosing of 3TC and FTC are super hard to both access and adhere to. Some of the recommended doses for FTC are every 48 hours, every 96 hours. Some of the doses for lamivudine require the liquid formulation. So I do think it's okay to round up to a dose that you can get and a person can take and monitor for side effects. And I think those side effects will be rare. But that was my whirlwind through what I think are the current highest controversies in antiretroviral therapy. But in the last 2 or 3 minutes, what did I miss? What do you think? What do you disagree with? We'd love to hear from folks.
While people are thinking about their questions in the last 2 minutes, I just wanted to say thank you to Dr. Wood. This is an outstanding, super high yield talk and summarizes all the recent literature and the controversies exceedingly well. So I think you were very clear, and I believe you answered these questions in the chat already as we went through. There is one in the Q&A about GLP-1 drugs and ARVs and the weight gain. You might have touched on that briefly, but there's not really a lot of data.
Yeah, thanks, Tricia, and thanks, David. I had the chat box open, but not the Q&A. So no safety signals. There are data suggesting that GLP-1 drugs are effective and safe for people with HIV. I find myself trying to get them for some of my patients in clinic. The biggest limitations are the cost of insurance, of course, and then the outstanding clinical questions, which I don't think anyone knows the answer to, like how long should people stay on them and what happens when people stop them and things like that. But no safety signals unique to ARV or people with HIV.
All right, we're right at time. Thank you again, Brian, for this outstanding talk, and thank you, everyone. Have a great
Thanks for
day.
having me.